think the big question now is, what's the utilization practice and how has that evolved over time? And I think, Sana, you are undoubtedly the world's expert on this, so I'm going to start with you to discuss that.
Of course. So as we showed you, really those older trials that were pivotal in proving the efficacy of the ICD were completed before 2005. SWEDEHF was published in 2005, and they really informed the guidelines in terms of telling us which patients to implant primary prevention ICDs in, so on and so forth. And so our group was really interested in figuring out if clinicians are indeed following the guidelines in terms of implanting these ICDs in patients who are eligible for these devices. And so this analysis that I'm showing you here actually was completed by our group using the AHA Get With The Guidelines heart failure database. And focused on patients with an EF of less than 30%, Get With The Guidelines, they were hospitalized for heart failure. But really the question was, what percentage of these patients who appeared to be eligible for a primary prevention ICD actually had one? And we were really surprised to see that only 35% of those patients had a primary prevention ICD. And then when we looked at sex and racial disparities, we were really surprised because we found significant gaps in care. Compared with white men, we found that black men were 27% less likely to have a primary prevention ICD. White women were 38% less likely to have a primary prevention ICD. And black women were 44% less likely to have a primary prevention ICD. So we were really disheartened by those findings. And in 2012, we decided to take another look at the data. As you know, the AHA Get With The Guidelines initiative is a quality improvement initiative. So we were hoping to see significant improvements in the utilization of primary prevention ICDs in eligible patients. And we were hoping to see those gaps in care closing in relation to sex and racial disparities. So what did we actually find? We found that the utilization of primary prevention ICDs improved, but only to 42% from the 30 to 35% that was found earlier. And then when we looked at sex and racial disparities, we found that the racial disparity gap seemed to be narrowing, but the sex disparity was still very evident. And more recently, data presented by Ann Curtis at the Heart Rhythm Society in 2019 meeting, where they actually analyzed close to 100,000 patients with an ejection fraction of 35% or less, who had a new class 1 or class 2A indication for an ICD or CRTD. And you'll see here on the slide, the results were really disheartening from my perspective to see a very low rate of utilization of these life-saving therapies of only 11%. And when they looked at men versus women, again, women were significantly less likely to have an ICD compared with men. So we still have a lot of room for improvement in this regard. And so many people have questioned, what is causing the underutilization? What is causing these sex and racial disparities? And this is not a simple answer. Certainly it is complicated, and I think there are barriers at different levels. The public policy and health system level, there are issues there in terms of lack of public awareness, in terms of access to care, patients with low socioeconomic status, to barriers at the provider level where clinicians may have biases or personal preferences, beliefs, so on and so forth, that inform their decisions, but also differences in how we as clinicians perceive patients' symptoms if they were men versus women, so on and so forth. And then at the patient level, there are some really important factors at play, especially in relation to like the sex disparity, where women generally are the caregivers in their families, and they may find it difficult to take time away from their duties and responsibilities to pursue a procedure, to pursue an intervention like the ICD. And of course, there may be some values, preferences, beliefs at play, and differences in the levels of education and socioeconomic status. So clearly this is not done. We still have a lot of work to do to try to understand these barriers and try to address them. But I'm really interested in hearing more about these issues in Sweden.
Thank you very much. And thank you for raising these very important points. And in one concerning finding in our analysis was that only 10% of patients with an indication for ICD for primary prevention of sudden cardiac death in the Swedish heart failure registry between 2000 and 2016 received an ICD, which really highlights the strong underuse of this therapy in patients with FRF. And I mean, there may be several reasons to explain this result. And one could be that patients with heart failure a majority of patients with heart failure are usually seen in primary care. And primary care physician may be less aware of the indications and of the importance of this treatment in heart failure patients, but they may have like higher perceptions of the complications which may be associated with this treatment. And in our data in the Swedish Heart Failure Registry, we try to understand which may be the reasons for underuse of ICD for primary prevention. And we saw that the strongest predictor of non-use was indeed a referral to primary care. And we also observed many other important predictors, which were, as expected, sex, age, and also socioeconomical characteristics, such as living alone versus cohabitating, and, for example, also like lower educational level. And this underuse of ICD, which is often observed in our court, is also observed for other heart failure treatments, meaning that the follow-up, the referral of heart failure patients may be more appropriate.
So yeah, it's interesting that we seem to have this topic of conversation about utilization. It's probably been for 15 years on this topic, and it's always comes back to continually trying to understand, even while other aspects of therapy evolve. Well, Michael, I want to turn back to you. So we've talked about the more recent trials, we've talked about changes in medical therapy. What's going on in ICD therapy? Can you comment a little bit there?
Yeah, so there's been lots of advances in ICD therapy, which I think have been very important. So one of the frequent complaints about underutilization has been that it's too expensive. Well, certainly the price of ICDs have declined significantly over the last decade, which I think is very important. And if we look at the number needed to treat, we see that it's certainly in line and often lower than many other therapies. Drug therapies are less expensive on a one-time basis, but over the course of years of a 10-year of an ICD, cumulatively, there'll be similar type of costs for those sorts of therapies. And certainly if we do quality of life year adjusted, we see it's very cost-effective ICD. So studies have been very, very consistent and will only get stronger, I think, as we do better with our patients and get less expensive devices. There are other important things that I think have eased the burden on patients in that we now, through a series of studies, know how best to program devices. So we program our defibrillators very differently than we used to. This has resulted in a marked reduction in inappropriate shocks and even some reduction in unnecessary appropriate shocks. With ATP therapy, we can reduce the shocks that the patients receive. So for patients, there are many fewer shocks than they used to receive, so it's a much better tolerated system. And I think in addition to all of these advantages, smaller devices, more comfortable devices, less costly devices, we've seen a progression of the therapy itself, the engineering of the therapy, going from the early days of abdominal devices, because they were so large, and surgical thoracotomies required to put patches around the heart, to then be able to start putting leads through the transvenous system, to then have transvenous ICDs, which were a major breakthrough. And now we have extravascular ICDs. So for those patients who are at high risk and don't require pacing for infection and other problems, we have devices that we can then put subcutaneously and again make it that much easier, less cumbersome, and potentially less complications than other devices. So certainly we've made great advances in the therapy as well as in the devices to be able to provide better, more cost-effective care for our patients.